You are listening to the Only Healthcare podcast. We are here to inform you on the whys, hows, and whats of healthcare. Hosted by industry leaders Michael Navin and Dr. Randy Vogenberg, here to discuss why are costs and risks so high and who should be held accountable? How will technological advancements merge with the quality of care? And when does the public get to gain access to these advanced medical treatments? Listen in as Michael and Randy seek to answer these industry concerns for the public and all stakeholders involved.
Welcome back to the Only Healthcare podcast, where we dive deep into the dynamics shaping the healthcare landscape. I'm your host, Randy Vogenberg, and today we're joined by Jayson Slotnik from Health Policy Strategies, LLC, where Jayson works closely with government agencies, manufacturers, patient advocacy groups, and healthcare providers to influence and understand policy changes. Jayson, it's great to have you with us.
Thank you very much, Randy. Really appreciate the opportunity to do this podcast and look forward to an exciting discussion.
Why don't you just briefly introduce yourself to our audience, and then I'll do a brief introduction before we start the questions.
My pleasure, Randy. As you mentioned, I am the principal at a health policy consulting firm called Health Policy Strategies. I've been running this consultancy for about the last 15 years. I left the practice of law to run this company. And my clients are drug companies, device manufacturers, some diagnostic companies. I used to practice law, and so I represent them in an advocacy point of view, help them understand what is going on in the Congress, but more so what's going on at the Centers for Medicare and Medicaid Services, CMS. I take that information and work with my clients to understand the commercial impact, helping them develop commercial strategies, patient access strategies, and then also do advocacy work to have the business drive the policy. In other words, have and conduct meetings with CMS to educate the agency and hopefully partner with CMS to provide appropriate access to innovative technologies that my manufacturers bring to market.
So let me start off by kind of setting the stage very briefly. 2025 brings disruptive forces to healthcare, a new government administration, increases in all healthcare costs, particularly for employer plan sponsors, a growing burden of chronic diseases, and frustration with both legacy players and innovators. Ultimately, what happens in healthcare in 2025 and beyond will be driven by some key questions, such as how do we determine trade-offs between access, quality, and cost? What is or drives or delivers health, and whose job is it to make decisions? Fundamentally, U.S. healthcare is struggling on policy and strategy across cost, quality, and access, leading to widespread frustration by all the stakeholders. So with that background and your experience, Jayson, let's start with a general sense of recapping 2024. Can you give us a general sense of where U.S. healthcare stood at the end of the year?
Wow, I mean, Randy, way to hit the ground running. I mean, that's such a great philosophical question filled with a lot of possible details. I think the best way to answer that, perhaps, is by sector. I'll start with the sector I know the best, which is the drug sector. Where we ended in 24 was better than where we ended in 23, not necessarily from a policy point of view, but from a certainty on the business point of view. Specifically, the industry now, the drug industry, has a much better understanding of most of the fundamental principles of the Inflation Reduction Act that was passed in August of 2022, and can now make much better assessments of their business. Specifically, we have greater information related to how the Medicare Part D as in David redesign works, how the patient out-of-pocket of $2,000 will be calculated, how those dollars can be smoothed as part of the Medicare prescription payment plan, working understanding of how the CPI penalty And then lastly, a very good working understanding of how the Medicare negotiation programs will work. So for the drug company, although some of that is bad news, at least there is some certainty. For some of the other sectors, specifically the health plans / PBMs, now they are entering into a level of uncertainty. They don't know what the Part D redesign will do for their drug exposure. How many more patients will go through the benefit? Will the abandonment rate for some of the higher cost drugs now actually hit their bottom line? How many patients will choose to smooth? And so they're having some issues about doing actuarial values of their benefit design, how to price it. They are in their level of uncertainty. And you combine that with continuing growth on the medical side because of just sort of more patients still recovering from COVID related to their model. And the PBMs, which service the health plans, as you know, on the pharmacy side, are entering into an even higher level of uncertainty because the Congress is seriously considering changing some of their business model because of some of the behaviors that the Congress doesn't like that are being perceived as anti-competitive and anti-patient. So we can get into that a little bit more detail, but the PBMs are entering into a higher level of uncertainty. On the provider side, I mentioned the hospitals, their costs continue to rise. Physician payments are going down in 2025 from a Medicare point of view, and the commercials are tightening up their reimbursement rates because of what we just mentioned before on their dollars. Mergers and acquisitions are continuing. So that's putting some downward pressure on contracting and pricing. So 2024 ended with some sectors having a better sense of their commercial fortunes going forward, some with somewhat of a better sense, and some others, as we mentioned, with a lot of uncertainty.
Thank you for that. So let me just do a very brief follow-up to that nice landscape from 2024. What were your thoughts on one or two key significant challenges or successes from last year?
From which industry, Randy?
From any of them.
I think some of the successes for the drug industry, right? It goes back to what I said before, which is the certainty. They gained some level of certainty on the Part D redesign, the Medicare program. I think one of the other successes for the industry maybe has to do with the 340B program, which we really didn't discuss. And that is a program that Congress established that allows certain providers, hospitals really, that serve underserved patients, the ability to buy drugs at a cheaper price and sell it at market price, to use those dollars to compensate it for uncompensated care, to serve the under and uninsured. That 340B program has grown tremendously, and we can cover that at a separate time. But some of the manufacturers are trying to get a better handle on the growth of that program, either through litigation or policy changes. So I think there might be some successes there. We've had some victories in the courts around the 340B program. So that is one of the positives. And I think for now, what I mentioned on the PBM side, while I mentioned that the Congress is coming forward with some reforms, it didn't occur last year. So the PBMs get to live to fight for another day and try to avoid that. I personally think it's going to happen, but the PBMs, one could argue, had a victory by not having any reform last year. In other words, there weren't any other major victories by any of the other sectors because there weren't any other major pieces of legislation or regulatory changes that occurred in 23 or 24, unlike 22 that had the Inflation Reduction Act. That's their victory, where nothing else happened to disrupt any of the other verticals in the healthcare sector, like site neutrality or PBM reform, like I mentioned. So I think the victories are what didn't happen as compared to something that might have happened.
That's a great perspective. I appreciate that. So as we sit here at the beginning of 2025, and we've just gone through a inauguration for Trump as the 47th president. We have a lot of changes already underway, some that are being proposed. We have a acting Department of Health and Human Services secretary right now as we wait to see what happens with the Senate. The executive orders Trump has begun to sign and put into play, which may impact some of the items that you mentioned from 24. They may be caught up in 25, including what will be happening around cost-saving measures now that Trump has signed a new executive order taking away what President Biden had put into place, such things as $2 generics and Medicaid, innovation for cell and gene therapies around financial affordability that would have started in 2027 through some innovation efforts. And then some other really broad-based things such as WHO, the Paris Accord, and so forth. So the question now is for you, Jayson, looking at 2025 and trying to project what's going to be happening in our world on healthcare, what would be the key changes or shifts that are being discussed in the Beltway?
Okay, so what's entertaining, if you will, you use that word in air quotes, about having a Trump 2.0 administration is that change is the only constant. At least the talk about change is the real constant. So there's a lot of just that, right? Talk. And so what's hard to understand or hard to really know here inside the Beltway is what is real and what isn't real. And I hate to use a Trumpism, what is fake news and what's real news, right?
Right.
I'm going to try to sort of piece that out, parse that out a little bit, right? The PBM reform is real as a concern of what could happen in 2025. What is also real is that the Trump administration won't reduce Medicare benefits or Social Security. They're not going to focus on those federal programs as a source of dollars to offset some of the other monies they want to spend. Rather, so starting at the big picture, you could look for significant changes in Medicaid and how Medicaid is structured. Some specific ideas being tossed about are work requirement policies, maybe block grants. In other words, giving the states a fixed amount of money. Right now, Medicaid is a fee for service. So the more the states do, the more money they get. Now, it's not a dollar for dollar, but still, it is perceived as a lack of an incentive to manage costs. So I think you're going to see a lot of talk about how to, using their words, modernize the Medicaid program. That'll be a big source of possible savings. I mentioned something before in the hospital community about site neutrality, trying to pay hospitals that have purchased physicians' offices at the same rate that they would have paid the physician's office had they not been owned by the hospital. So in other words, you have a physician's office across the street from the hospital. The physician's office performs a procedure. They bill the government. They get paid X dollars. The hospital comes, buys that physician's office. Same procedure. The way our system works, the hospital gets reimbursed X plus. And so there's been some talk over the last couple of years about trying to neutralize, make that payment the same, regardless of whether it was in the physician's office or in the hospital outpatient department. That generates a lot of savings for the federal government. So that's a big policy that the Congress may look to implement, to take those savings so we can do tax cuts or other kinds of policies. Those are the big healthcare issues. Then there's a lot of sort of tweaks around the edges that the drug companies want that may or may not happen. And then the other big issue, speaking of providers, is what do you do and how do you pay physicians? The MIPS and those kind of programs that pay for quality have sort of run their course. Physicians are still subject to a conversion factor that I can explain. But what has resulted is physician payments have gone down, not only in real dollars, but certainly inflation adjusted dollars significantly. So the Congress has a lot of healthcare issues on its plate that it could address. But ironically, Randy, they're not the top issues for the Congress. So I don't expect anything that I just mentioned to hit the Congress's desk in any way until second half of this year. Rather, what will be focused on is what you've already seen here is immigration policy, and then slowly now we'll get into tax reform.
Those are some great points. Can you share any insights on some of the talk and upcoming policy changes that might happen around chronic disease prevention and treatment as priorities as part of this Make America Healthy Again agenda?
Yeah, no, that's probably a 17-hour podcast in and of itself, Randy. So as you mentioned, the Make America Healthy Again initiative is being driven by the Secretary of Health and Human Services nominee, Robert Kennedy Jr. He's been talking for years about his displeasure with a healthcare system that seems to be motivated to keep patients chronically ill, and wants to reevaluate the entire healthcare system to focus more on prevention and to avoid this sort of chronic disease state. And what he specifically means about that is not really clear. What he can do about it is also not really clear because, as I mentioned before, the Congress is the one that writes the rules. CMS, which is the agency under his jurisdiction, implements those rules. So specifically, there are specific rules about how physicians get paid, how hospitals get paid, what services are covered, what drugs are covered. So he, in and of himself, doesn't have a lot of autonomy to change those rules because they're very prescriptive from the Congress. But what he could do around the edges is do some demonstration programs with two-sided risk to physicians and hospitals that focus more on prevention and longitudinal health improvements, right? Measures along those lines. So we shall see what those details are. But I caution a lot of people to remember that we have a significant infrastructure here that he's going to run up against that would prevent any dramatic swings in the way the healthcare services are delivered.
So, switching gears a little bit, but kind of looking at it from a couple different perspectives, looking at some of the unfinished business around health policy. In the commercial sector, some of the hot topics that I run into with other consultants or brokers include three major areas. One is affordability or new funding models for healthcare, either products or services. Secondly, leveraging carrier or integrated innovations into the care delivery model. And then simplifying benefits delivery. Is anything along those three lines entering into the congressional discussions that you're talking about? Or is that more of potentially a regulatory, or just commercial market's going to drive its own thing?
No question, the commercials are going to drive it, right? Because they have greater flexibility, they can move faster, which is an amazing statement in and of itself, given the largesse of the commercial payers. But yes, you'll see the innovation in those different types of initiatives coming from commercial first. I don't think the Congress is going to legislate to that level of prescriptiveness, maybe, but I'm very skeptical that this Congress will get into that level of detail to drive that kind of level of change from an infrastructure point of view. Now, where I argue against myself about to do that is, like I mentioned, changing physician payments. That's where maybe the Congress will get involved and try to do what you're mentioning, Randy. I'm skeptical that that's actually what's going to happen. Now, you mentioned demonstration programs, regulatory point of view. If this was not the Trump administration, I would say yes. You have a better chance of that happening through what's known as the Center for Medicare and Medicaid Innovation. But as you mentioned, heading into the beginning of this call about some executive orders that have stalled some of the current CMMI initiatives, the Trump administration is not a big supporter, proponent of CMMI. And I don't think will drive some of those other kinds of care models that you mentioned, Randy, through CMMI for Medicare or Medicaid patients, which is why I led off with my conclusion that it's going to be the commercial that leads the way.
Okay. So is it safe to say that when we reflect back on the past 5 years and some of the major trends that you've talked about or I mentioned, both government and commercial, how do these trends inform what we can expect, not only from 2025, but even looking out further towards the end of this decade? particularly concerning commercial insurance?
Well, that's a good question. So here are my thoughts. Commercial insurance is going to continue to receive a lot of populist pressure.
Mhm.
That's already started as a result of the tragic murder of United CEO. You saw on social media this undertone of populist angst and anger regarding the way insurers behave. I think this administration is going to pick up on that. They don't have to pick up far on that because even the Biden administration was putting forward and implementing policies that were providing greater oversight on the way commercial plans conduct prior authorizations, scheduling, network design. So the government was already sticking more of its camel's nose under the payer's tent. And
Mhm.
so I think that will continue. There'll be greater scrutiny on commercial. Will they be forced to diversify and break up? No, I don't think so. They may wind up doing that on their own as a result of A, what I just said, and B, the PBM reform that's requiring greater transparency between the PBM and their customers. So, towards the end of the decade, we'll have a lot more information about these business practices. A greater groundswell will continue regarding payer denials, delays, why are they so profitable? I think all of that will continue. But all of that having been said, Randy, almost everything that we've talked about for the last 20 minutes, and this is my opinion, could all be dramatically altered depending on how artificial intelligence and LLMs are being used in healthcare in ways that we can sort of think of and ways that we even can't think of going forward. And so we could be here 5 years from now and we could have a completely different healthcare experience as a result of those, AI and LLM changing the way healthcare is distributed and disseminated and provided in this country
Mhm.
if you're going to use a 5 year window.
Good point. Kind of along that line, as we start to dig down into some of the areas of legislation and reports recently, there was an IQVIA report about what's indicators of progress, looking at 2025, and you hit on a lot of those things, such as trust in companies, whether they're third parties or life sciences companies. Reduction in out-of-pocket costs for patients, part of the changes, along with better patient access, so forth, all that. So let's start with PBMs, because you mentioned legislation on the PBMs that didn't really make it this year, but will be a major target for 2025. Can you just elucidate a little bit more about the impact that you foresee that those changes would have on the industry, not only the PBM industry, but just healthcare in general, because of the overflow effect onto patients, providers, and so forth?
Let me clarify what that reform is going to be above and beyond some of the transparency that I mentioned, because that will help give a greater understanding of the impact, right? So, right now, Randy, if you are running a PBM or a GPO and I'm a manufacturer, and you come to me and you say, hey, Jayson, you're the manufacturer, I'm going to provide access to your drug, you're going to give me rebate dollars. And if you want data, I'm happy to sell you the data. And I'm going to say, great, how much is the data? And you're going to charge me a fee for the data that is directly linked to the price of the drug. And the Congress is not happy about that because now you and I are incentivized to increase the price of the drug, right? Because you make more money. If I'm paying you 2% or 3% of the drug cost, when I raise my drug price, you make more money, even though you're doing the same work. So the PBM reform is going to require a delinking of the price of data and portal fees and other fees from the drug price. You can no longer charge me a percentage of my drug price. You must charge me a dollar figure. So in other words, everything that I pay you for, like the data or to enter the portal or other kinds of services, must be a bona fide service fee at fair market value. And that's what's in the law.
Mhm.
That's going to be a significant transition of the business model for the GPOs and PBMs and how they then contract with manufacturers. Those are hard habits to break. You're introducing new legal and regulatory concepts. Not so much new because it exists on the medical side, but certainly breaking a lot of old ways of doing contracting and introducing new, bona fide service fees into how they're valued. And that's going to take some time to implement and then to settle out as what the market can bear and not bear and how these entities behave and not behave. That is going to be one of the significant issues for the next 5 years, should the legislation go through.
Yeah, and you bring up a good point about a lot of these approaches to better managing information and the money flow exist on the medical side, but have not on the pharmacy benefit side. So a lot of these changes are going to be focused on the pharmacy benefit that is relatively new, as you pointed out. There's some other information that's come out from both the Office of Inspector General and from CMS, different reports, a couple of publications that have been critical on PBMs. So how have those reports shaped our understanding of their role in healthcare? Or did we already know what these reports say?
Right. So that's a great follow-up question there, Randy. So there are a couple of government entities like GAO and there's OIG and there's MedPAC. There's no shortage of entities that are either government entities or quasi that issue reports on what's good and what's bad and how to fix it in the healthcare sector. So those couple of reports have come out over the years regarding PBM, regarding site neutrality, regarding physician payments, regarding hospital costs, regarding overpayments to Medicare Advantage. All that information is out there. Just a matter of when the Congress wants to get around to use that information, when it's in their favor to issue and try to implement reforms. None of the information that's published by those entities is surprising to those of us who follow whatever sector the report is reporting on. If they're like the Federal Trade Commission came out with a report regarding some of the negatives of the vertical integration of the PBM model, nobody who's in the drug industry or otherwise was surprised by the FTC findings. But, you still need to go through that exercise because that's what serves as the backbone for change, right? So when the Congress and or a regulatory agency wants to change something, they get more credibility in that change if there's an FTC or other kind of government report that validates and supports the change as compared to a pharma or a hospital or even an IQVIA report that is going to be paid for by somebody else. So you need these reports. It's part of the legislative sausage making process, and that's how it works.
Okay, so there were a couple other reports kind of along that line. The Congressional Budget Office focused on sickle cell, and the Office of Management and Budget on Medicare and healthcare costs. What did we get out of that? What was the key takeaway that our listeners should be aware of?
I think the key message that our listeners should understand is that, and I'm going to make it a very big picture message, that when the Congress implements law or makes a legal change, right, there are a lot of those reports that support the policy change, at least in healthcare. Going back to, the Medicare Modernization Act in 2003 that stood up a Part D pharmacy benefit, there were lots of reports about how patients didn't have pharmaceutical drug coverage and how bad that was. And starting from there, and even before that, going forward, there usually are a lot of MedPAC and GAO reports that support a legislative change. Now, what that legislative change ultimately becomes is usually a political negotiation. So, for example, the $2,000 out of pocket, everybody sort of knew that it was bad policy not to have an out of pocket on the Medicare Part D side. So that was well supported by reports. Where the Congress drew the dollar figure, 5,000, 2,000, 3,000, that became a horse trading political message and a costing for the government to try to fit in the benefit. But with the policy changes are usually supported, and then some of the details are traded for based on politics.
Building off of some of these reports, particularly in a health affairs article that came out at the end of last year that CMS provided looking at overall healthcare costs, there were a lot of implications on the commercial marketplace, and it could affect the commercial trends going forward, particularly when we talk about the price negotiations for Medicare as just one example. So there's a lot of implications from the government sector on the private sector, commercial insurance,
Right.
by some of these things that do come out. So my question is, what's your take on how are commercial trends likely to be impacted by what may come out as new regulation or legislative change?
Using history as a guide and take that for what it's worth, commercial has always been influenced by Medicare when it benefits the commercial marketplace. So, for practical purposes, the 10 drugs that are now at a much lower price, you would anticipate as we get rolling here into commercial contracting for 2026, the commercial payer will come to the table with the maximum fair price, the negotiated price for those drugs, in their pocket to try to get more money from those manufacturers. There's no question in my mind.
What would you say are some of the specific cost shifts that we should be aware of, either good for commercial or bad for commercial, as we look forward over the next year or two?
Oh, I think the trends have always been there and probably will be accelerated of cost shifting to cheaper sites of care from the commercial point of view, inpatient, outpatient to physician, physician to the home. That will continue, and could be better for commercial. It could be better for the patients, right? From a convenience point of view. I usually don't oppose those kinds of initiatives. The providers usually get hurt, but if it's better for the patient, then that's the way it should be. On the Medicare side, you're going to see that much more aggressively because of the way the Part D benefit works. I'm guessing that you'll see a lot more medical benefit drugs being pushed to the pharmacy benefit side.
So is it safe to say that we may actually see more of an integrated benefit emerging in the next?
No question. No question, Randy. I think you're going to see a lot more of the medical and pharmacy benefit drugs merging into one of more of a global formulary. Many more of the medical benefit drugs will be managed by the Medicare side because of that significant cost differentiation between B and D, and that'll bleed over into commercial.
Interesting. Well, that's something we definitely have been talking about for a while.
Yeah.
It'll be interesting to see if that moves faster than we think after all these years.
We'll see.
Yeah, we will see.
Yeah. This is the year because of the way the 25 redesign. This is where it's going to start a little bit. And then by the end of the decade, it could be significant.
Okay, great. So we want to wrap up and leave some tidbits for our listeners. Based on the discussion, a brief one, albeit, that we had today on some of the health policy areas, what would you say are the key points our listeners should take away about the future of healthcare policy and the impact on their lives?
Two things, right? I'm going to start from the big picture. I'm going to go back to the artificial intelligence. I would monitor what and how this government will regulate AI because it can be so disruptive, starting from diagnosis to treatment, the way it can change healthcare. What this government does on AI is something that everybody should be following. And then number two, what does this populist government, because this is a technology government, they're positioning their way, that's why AI. And then secondly is, as a populist government, how do they leverage that sentiment, that quote unquote support to try to really drive down prices across the board? Hospital, drug, physician, health plan, insurance, whatever it may be. Those big pictures are on the table and can impact day-to-day lives in terms of cost and access to healthcare services. And that's what I would sort of focus on. Whatever catches your fancy, then you can double click and try to get more information on it. But those are going to be the two big, philosophical issues that this government's going to try to push.
Yeah, for those that haven't been paying attention to strategy in their plans or their operations, they better buckle up and get ready, because I'm seeing the same thing with some very strategic changes are being started that will have very important implications, whether you're a plan sponsor, a provider, a manufacturer, et cetera. That's a great way to summarize things. So that very high level with technology in particular. For those looking to stay informed and engaged, Jayson, what resources or any specific actions would you recommend for our listeners?
Starting at a high level, right? Any kind of, national newspaper, just Google Smart Briefs, and there's all kinds of topics there. And then there's all kinds of healthcare focused trade newspapers. They can reach out to you, Randy, or me, and we can help them do that. The Congress and all the different committees have daily emails on that. And there are other kinds of specific podcasts that also can do it. But the big issues that we just talked about are going to be covered by the big newspapers and the big news. And then from there, you can, like we said before, just drill down into any specific issue. I mean, because all of it depends on your politics and your time. So I'm not going to give anything very specific, but, people will figure out how to get there.
Right. As always, things are constantly changing, particularly in healthcare, in our extremely complicated environment that we both work in. Well, Jayson, I want to thank you for sharing your insights and expertise with us today. It's been very insightful having you on with us today, and appreciate your time.
My pleasure. Thank you very much, and look forward to many more.
Absolutely. And so to our listeners, thank you for tuning in. Keep engaging with us through our website, onlyhealthcarepodcast.com, and social media, almost all the platforms that are out there, to stay updated on the latest in healthcare. Please share this episode with your colleagues or friends that you think could benefit from this discussion. We look forward to seeing you in the next episode of the Only Healthcare Podcast.
Thank you for tuning in to the Only Healthcare Podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.